All right, my name is Dan Gillett. I am the Vice President of a couple things at McLaren Homecare Group. But for today's purposes, I'm here as an occupational therapist because that's what my background is. And I've been a therapist since '93 as an occupational therapist. And I started work at Beaumont Hospital in Royal Oak and Troy. And I decided at that time, being a young therapist, to start to do a couple home care visits just to see what it was about and to learn a different specialty area of therapy. And what started out as, I don't know if I'm going to like this going into patients' homes and what you run into going into patients' homes, quickly turned into, as a therapist, I really felt like I could make a difference in their home environment to be able to keep geriatric patients at home, which is predominantly who we work with, but to, instead of as a therapist working in the outpatient clinic, are working in the inpatient unit and trying to simulate their home environment and trying to do their rehab and their treatment to prepare them to go home in their home environment. It was awesome to be able to walk into their home and actually see their setup and see the things that they're going to have to try to deal with to get to the bathroom, to see what they're going to have to do to try to get into the home, to see the family dynamics that they're dealing with when you talk about patient compliance and what are things that are interfering with them in completing that. So, as a contingent therapist working for McLaren at that time, I decided to go full-time into home care, and I did that for about 7-8 years, full-time before I got into some different management functions. And it's been tremendously rewarding as a therapist doing that, and I still continue to see therapy visits. I can only carry about a patient or two at a time because I'm doing my other job, but it's just incredibly rewarding to be able to go into that patient's home. And days like today where it's raining, or in a couple months where it's snowing and you're trying to get through 6, 8, 10 inches of snow down a dirt road, to be able to see this little old lady who the only way she's going to be able to stay in her home is because the nurse is coming out or the therapist is coming out trying to keep them stronger, get them the equipment they need to be able to function. So again, I got into it thinking, I'm just going to try this. And 18 years later, here I'm still doing home visits, and I'm in management and doing things to try to impact all of the 1,500 patients we may have on service at any one time at McLaren Home Care Group. So always exciting, never dull moment. Again, I don't know from a medical residency standpoint if there's a home rotation or home visits done within the rotation. But some of the things that I've run into in patients' homes, from cleanliness issues to family dynamics to never know what you're going to run into, is pretty remarkable. But again, when you see that person be able to stay in their home and be able to function independently, that's the reward as a therapist that we get from working with our patients. So that's just a little bit of overview of myself and how I got into home care. I'm going to go through today some of the things of what a normal visit schedule looks like, or what we do as therapists. I'm going to do a couple overview slides here, but we'll do some demonstration, a little bit of hands-on stuff too, and try to get you out of here a little bit early for your next class or studying or whatever you need to do. So, I got to pull up the other presentation, don't I? Sorry about that. While I'm doing that, I'm a self-admitted Michigan fan, so I just want to say congratulations to all of you last weekend. I missed the entire game because I was at my son's cross-country state meet. But I don't think I missed much from a Michigan fan, but I'm sure if I was on the other end, I would have felt that way. But okay, home health care from a therapy process standpoint. When we go in, we receive an order from the physician. It'll either say evaluate and treat or have specific orders related to therapy, what we're going to be doing in the home. Oftentimes, though, it is evaluate and treat. So we'll go in and we'll make the assessment. If nursing's in on the case, the nurse will go in and make the assessment first. We have to see that patient within 24 to 48 hours of that physician order, and we receive that referral. If nursing is not in on the case, then a physical therapist has to open the case, or a speech therapist. Then we begin our therapy evaluation process and complete a document that's called an OASIS, Outcome Assessment. Can't remember all the acronyms, but it's about 80 questions, radio button questions on our EMR system. All of our nurses and therapists are on tablets. So we have the complete medical record right at our fingertips to be able to pull up, what did the order say, what's the patient's past medical history, what occurred to them at the hospital, in the nursing home, etc. So we complete the OASIS assessment. and establish our plan of care. So apart from the physical therapy portion standpoint, some of the systems that they'll look at from an evaluation standpoint, they'll look at ocular motor system and because of the impact that that has on balance. We'll talk a little bit about that, about BPPV in a moment. We're going to look at balance from a physical therapy standpoint, dynamic, static, standing balance. We're going to look at, do they have central nervous system balance issues? Do they have peripheral nervous system balance issues with their vestibular system? We're going to look at coordination. We're going to look at musculoskeletal with manual muscle test, range of motion. Just trying to, again, do an all systems analysis to see what's going on with the patient. Again, we've got the order. We've got what you want to do as the physician for the patient. We're going to follow that order. We're going to make that overall assessment. When we get done with the assessment, we always have to call the physician to clarify our orders, to explain what we saw. Here's what our plan of care is. Or if it differs from what your orders were, then we'll ask for a change order. Okay, continuing on the PT evaluation, we'll look at sensory. We'll look at the functional status of the patient. They're doing gait analysis, do transfers, do look at movement disorders that they may have. We heavily look at special tests, and this is one of the things as a therapist that, again, when I came from Beaumont, in the hospital, I was working inpatient rehab and outpatient. So it was nice because I was in a nice clinic area like this. I went over to the cabinet. I grabbed out whatever test I needed out of the cabinet. I grabbed anything that I needed to be able to do to assess the patient and what their functional level was at. I go into home care, and you can't lug all that stuff around in that patient's home to do standardized tests and assessments to be able to identify exactly where they're functioning at. So you have to be creative in some standpoint, but we still try to, as a home care agency, we really try to balance out, make sure we're looking at standardized testing along with functional ability so that we can, again, determine baseline, just like any assessment, to determine baseline, provide treatment with our therapy that we'll talk about in a minute, and be able to reassess how they've improved since the beginning. So some examples of tests. Ortho test, again, I mentioned manual muscle test, range of motion test. We may do tests for bursitis or neuritis or other things that are just standard tests that, as I walked in here today, saw you performing some different tests probably. From a neuro standpoint, again, looking at cranial nerve testing, ocular motor testing, balance testing. From a gait standpoint, I'll talk about the tug in a minute, the timed up and go, and I think I have a patient here that's going to help me out. But we also have standardized tests, maybe you're familiar with the Tonetti or the Berg balance scale, or gait speed test, or the DGI. So again, these are tests that are built into our EMR for our therapists. They also have cheat sheets that they can use within the home. But again, the whole standpoint is make sure we've got standardized testing, baseline status of where the patient's at, and objective assessment of where they're at rather than just jumping to a feel standpoint. Okay, and modified CAT-SIB test. This is one of my favorites because, actually, Whitney, why don't you come on up for a modified CAT-SIB? I'm going to jump right into a test here and probably not being blinded here. So maybe we can stand out here for a minute. So actually, in the home, what I'll do is I'll bring in a piece of about 4-inch foam for the patient, because what I need to look at for their balance is I need to look at their ocular motor and the impact that has on their balance. I need to look at their somatosensory, so they have issues going on in the lower extremity in terms of their ability to feel where they're at balance-wise and to adjust. And we also need to look at the vestibular system. So one of the tests is called the modified CAT-SIB, or MCTSIB. And so I'll go in and I'll talk to a patient and I'll say, okay, Whitney, what I'd like for you to do is we're going to go ahead and stand with our legs together and our arms crossed, and I want you to go ahead and just keep your eyes open and look straight ahead. What I'll do is I'll just start the stopwatch. I'm just trying to see if she can go to 30 seconds without losing her balance. Again, we're talking about a geriatric population. If I do this test, she's not able to conclude this test. She scored a 0 out of 4, and the test is over. Okay, I know I got balance issues right now just with static standing. So I, as a therapist, am looking at this and saying, okay, if we've got static standing balance issues, I probably got issues when she's trying to stand to pull up her pants from the toilet, when she's trying to stand at the sink and brush her hair, when she's trying to stand at the sink and brush her teeth. So let's say Whitney passes. Okay, great. This is a 1. Next test what I want for you to do. So right there, For Whitney's balance, what is she using primarily? Visual system for her balance, right? She can see everything. She's got somatosensory with her feet feeling into the ground. She can kind of tell what's going on there. She can use any sense, whether that's, again, ocular, motor, somatosensory, vestibular. Okay, Whitney, what I'd like for you to do now is go ahead and keep your legs together, arms crossed, close your eyes. Okay, so I took away one of the senses, right, for their balance. How does this relate to the elderly geriatric population? Well, how many times do they have to get up in the middle of the night to go to the bathroom? How far is it from their bed to the light to turn on the switch to get there? So if we've taken away a visual sense from an 80-year-old geriatric patient, we've already incredibly increased that risk for fall just with getting up in the middle of the night to do that. So if Whitney fails on that test, I know I may have a problem with balance and looking at how to adapt the home to make it safer for the patient. Okay, so Whitney passes with flying colors on that test. She's quote-unquote normal, which is subjective, right? Not for Whitney, but for all of us, especially Michigan fans, right? Okay, the next test, what I'll do is I'll place the foam under Whitney's feet, because now I want to test somatosensory and see how she can adjust with that, and also a little bit of sway from a vestibular standpoint to see if her body can adjust with a vestibular system. So again, I'll place the foam underneath there. I'll say, Whitney, okay, go ahead and step up on the foam, legs together, arms crossed, eyes open. Still giving her all her senses, right? She's got visual, she's got somatosensory, she's got vestibular, can use them. 30 seconds, okay, she passed with flying colors. So far she scored a 3 out of 3 on the test. Last and most difficult, which we don't see a lot of patients that can pass this one, I'll say, okay, you're still standing on the foam, arms crossed, eyes closed. So now we've taken away visual, right? And we've taxed the somatosensory to adjust. And now we got a little bit of sway, and we got vestibular trying to adjust because I can't see visually what's going on. So to think about that in relation to the home environment, again, it's late at night. There's clothes on the floor. There's a thick shag carpet for them to get to the bathroom, or they're walking outside at a family member's event. They're walking on grass or the ground instead of the sidewalk. You know, all those things that you look at functionally and say, how is their balance going to be impacted by all these different environmental forces that are coming on them? So, okay, thanks, Whitney. Mm-hmm. So that's just an example of one test. Again, trying to look at standardized test. What does the test say, but so what? Okay, how can we relate that as therapists to how does this impact their ability to function in the home safely and independently? And that's the key with any of the tests that we do. So I would say as a therapist, you know, when I was working full-time in the field with our geriatric population, you know, probably 75% of the patients are Medicare. The other 25%, you know, maybe under Medicare. You know, as Whitney went through some of the conditions, their reasons for home care may have been due to a surgery, an accident, etc. Okay, timed up and go tests. Very simple, and this is one that can be done in a physician's office too, to be able to check patients' balance and safety. So let's go ahead and move the chair out here. Patient Whitney, if you don't mind, we're going to place her right here. Timed up and go. Did you guys get the handouts on this electronically? Okay, so it's just very simple. I can do about 3 things at once here when I'm testing my patient out from a therapy standpoint. I'll say, okay, Whitney, what we'd like to do is we're going to walk to the green bag there. Okay, so about 10 feet, 3 meters. We're going to walk to the green bag when I say go. So we're going to stand, we're going to walk, turn around, come back, and sit down. I'm just going to time you, Whitney, to see how long that takes you to complete that. Okay? So what am I seeing as a therapist? Number one, I'm seeing, can they follow multi-step directions? I'm already looking at the cognitive piece with them in the home. I'm looking at, you know, a common chair that they like to sit in. Can they get in and out of it? I'm looking at transfers. I'm going to be looking at balance when they're walking and come back. And I'm going to be looking at gait speed, which is a predictor of morbidity and also falls. Okay? All right, Whitney. On your mark, get set, and go. We're going to stand, walk over to the green bag, turn around, and come back. Good, thanks. So Whitney's quote-unquote normal, 5 seconds or less there. Thanks, Whitney. You can go ahead and move that chair back, too. Typically what we'll see is a lot of, and I think it's on the slide here, greater than 14 seconds is the cutoff for fall risk. I think your sheet said 12 seconds from the CDC, so they were a little bit more conservative from that standpoint. But if you look at this handout here, from a patient standpoint, less than 10 seconds independent fall risk, no. 10 to 20 seconds mostly independent fall risk. I would say probably in that 75-80% of our patients aren't doing this within 14 seconds when we do an initial assessment. Again, initial assessment's giving me the information to say their fall risk, what are the treatment approaches I need to do so I can improve them over the 3, 4, 5 weeks that I'm going to be here working with them. So very easy test with good standardized norms to be able to identify normal scores. Okay, gait speed, which I've kind of already mentioned a little bit, but it correlates with overall patient morbidity. You may notice this in some of the patients that you're seeing as residents. If you see the patient ambulating, you walk into the hospital room and they're coming back from the bathroom, you've probably experienced this, and it's, okay, you're looking at your watch and it's about 3.5 minutes for them to get back to the bed. Okay, that's an automatic predictor of, obviously they're a fall risk. Obviously they're medically compromised and increases the morbidity of the patients in terms of studies that we've seen from a clinical end. So again, we're just talking evaluation at this point. It gives us goals and treatment approaches we can use to work on with the patient. Okay, BPBV, which is always a tongue twister for me. Benign perioxal positional vertigo, sorry. So you're talking about semicircular canals, the utricle and the saccule in terms of the otoconia, okay? The otoconia, or quote-unquote, the rocks in your head getting loose and getting in the semicircular canals. This is probably something you guys have had lots of training on. But as a therapist, again, when I'm going in and evaluating that patient and I'm looking at, is there a CNS issue going on in terms of their balance? Did they have a stroke? Do they have a neurological condition? Do they have a medication issue that's causing the dizziness? Or has it been sudden onset of their condition? This balance, lightheadedness, when they change their position. You know, we're going through a series of analysis to determine we may have a BPPV here going on with the patient. So our therapists actually are trained in this from a vestibular rehab standpoint. We'll do the Dix-Hallpike test. We'll roll that into an Epley maneuver if a patient needs it for treatment to try to, again, dump the otoconia back into the utricle or saccule. Okay? So we don't see a lot of these types of patients, but we do run into a fair amount of them. We've been able to have some good outcomes with our patients related to this. But again, the whole goal of this is to be able to correct the otoconial issue and rehab the vestibular system. This just shows you some standing balance exercise, so it just shows you a patient in a home. In terms of, again, at this point, the last slide here, we were still on evaluation. Okay, now we've moved into, after the evaluation is completed, we're calling to the physician, saying, here's what we saw on Mrs. Jones. The order stated this. We're also seeing this. Here's our plan of care. I'm going to be out there 3 times a week for the next 6 weeks. Are you okay with this order? Physician or physician's agent calls us back, approves the order. We send that through with the 485 that maybe you, if you've ordered home care before, you've maybe seen a 485 come through, which has got our whole plan of care on there with all of our orders and treatments we're going to provide to the patient. Now we're into the treatment part. I'm into the 3 times a week for 6 weeks to care for the patient. What did my test show? What did my functional scoring show with the patient? You know, how exactly are they performing and actually providing the treatment, whatever that may be for that patient's needs, standing balance, gait, ambulation, transfers. Again, always looking at functional. So when you ask questions about homebound, you ask questions about how long can a patient be recerted in terms of 60-day episodes. Again, just like any other insurance-based requirement, can we demonstrate medical necessity? Can we demonstrate progress with the patient? If we're able to demonstrate those on an ongoing basis, I've worked with patients before in the home for 6 months before I was able to get them to a standpoint where they could go to outpatient therapy to continue their care. So that's kind of a normal progression, is that from a therapist end, we'll see patients from the hospital, from the nursing home into home care. The last couple patients I had, I worked with them for about 4 weeks, transferred them to outpatient therapy. Called the doctor, said, Mrs. Jones is ready to go to outpatient therapy. Can you fax over the script to this location, unless the doctor had another preference? Okay, just treatment I already mentioned on the BPPV. Other modalities from a physical therapy standpoint, treatments that we do in the home is modalities, ice, heat, electrical stim, manual therapy. We do ultrasound in the home for a patient. A good example of this is when you got a stroke patient. who's got tightening of the shoulder or the coracal humeral ligament shortening here because it's not moving the arm, or they've got a lot of tone in the arm, so they haven't been doing good range of motion. And now you've got a shortened ligament, and they're starting to get active motion back. Now all of a sudden you got active motion back, but you got orthopedic restrictions because they haven't been stretching and ranging with their arm. Well, maybe we need to bust some of that up a little bit with range of motion. Use ultrasound prior to that. Okay, now we're on to occupational therapy. And again, the 3 disciplines in the home, just like for outpatient in the hospital: PT, OT, speech therapy. From an OT standpoint, similar to PT, we'll do a systems review. Just from and I'll verbally walk through from an OT standpoint, what a common eval visit is like working with the patient. We were going to think about maybe doing a demo, but that's okay. Patient Whitney will hold on that. But from an OT standpoint, I'll get the order. I'll go into the patient's home. Typical flow of an evaluation visit for me, besides the nice introductions we'll do in the first impression we're trying to make on the patient, again, to develop that relationship, because we might be with them 3 times a week for 6 weeks. They've got to be able to, number one, trust us to come into their home, which sounds a lot easier than it is sometimes. Okay, this is very uncomfortable for a lot of people to have people come into their home. So the whole dynamic from you as physicians, where they're coming to you or you're going into their patient room, they're coming into the office, has changed because now you're on their turf. And it's a respect that you've got to be aware of when you're going into a patient's home. So that first visit's important to be able to establish that trust. And then I'm jumping into evaluation, so I'm checking all the vitals. I'll jump into my systems review, similar to some of the tests from the PT standpoint, the standardized tests from the PT. I'll also do a functional home assessment profile that we do, which is again, I don't know if it's got standardized norms to it or not, but it's a very structured assessment for assessing the patient's home. It goes into every room basically in the house, and it asks you, is there a risk in the room? How frequently do they visit the room, so that you can come up with a fall risk assessment number for their home. Again, as an OT, I'm looking at that and saying, okay, I'm getting a score on that, but what does this mean functionally so we can prevent a fall for the patient? ADL assessment on the first visit. After I do vitals, after I do manual muscle tests, after I do range of motion, I'm getting them up and I'll say, all right, let's walk to the bathroom that you commonly use. Okay, I want to see them in action. I want to see their ambulation. I want to see their balance. I want to see all those things put together. I want to see them sit and stand from the toilet. I want to see them try to transfer in and out of the tub or the shower, whatever they have to normally do, so I can get a good functional status of where they're at. Again, because I'm trying to identify, okay, if they got a balance issue to get in and out of the shower, what's the treatment exercises I need to be able to do to improve that so I can take their shower transfer from mod physical assist to contact guard assist, so they can just have someone stand by them to get in and out of the shower from the treatment perspective. I'll typically then walk them into their bedroom that they commonly use. I say, okay, show me how you get in and out of bed. And then I'll have them sit on the edge of the bed and I'll say, okay, show me how you take off a sock and put it on. That's when everything falls apart, okay? When they're trying to reach over, trying to get that sock off, trying to get it back on. Again, what am I looking at? I'm not necessarily looking at just can they get their socks on and off. I'm looking at the dynamic sitting balance, okay? I'm looking at safety issues. I'm looking at, are they aware of safety issues? Or are they just going gung-ho at whatever I'm asking them to do? So again, I'm doing multi-system review. Any functional tasks that I'm having them try to do, I want to be able to see all these components at once. Oh, and then if they're high enough functioning level, I'll say, okay, let's walk to the kitchen. Again, I'm checking ambulation, I'm checking balance, checking safety. Again, all the time, because it's the first visit, I got my gait belt on them. I'm prepared in case they lose their balance. Okay, it's the first time I'm working with them. We walk into the kitchen, I say, all right, show me what's a common breakfast you eat? A lot of times it's cereal, whatever. I'll say, okay, get the stuff out that you use for breakfast. And again, we're talking about a high-level patient. So we're talking about the 20% of the patient population, the other 80. The bottom portion of this might be bedbound patients. There's a group in the middle that can't do all this stuff that I'm talking about. And this higher level, 10 to 20% patient, I might get this far in my first day evaluation, going through the modified CAT-SIB, going through the timed up and go, walk to the bathroom, walk to the bedroom, etc. But if I can get them into the kitchen, what am I checking? I'm checking, again, dynamic standing balance. Let me see how you reach into the fridge and pull out that 8-pound gallon of milk, be able to carry that over to the counter. Let me see how you reach up in the cupboards and grab the cereal out. Let's see if you reach behind you in the kitchen rather than turning your body and trying to keep your belly button facing what you're doing, and do you lose your balance? So again, I'm doing multi-system review in a functional way to identify where does treatment need to occur. Home modification on this slide, as Whitney mentioned about some of our specialty programs. An example of home modification, I've given you some safety-related recommendations based on our functional home assessment profile that we would do. But in addition to that, with our low vision program, I'll look at it and see if they've had visual changes and can they function again within their kitchen and use the things they need to be able to do to get a meal or things of that nature. Okay, I'm going to skip over those slides. So again, that gives you a framework of when Dan walks into the home to see this patient, this is what visit number 1 looks like and what we do and how it relates to your orders as the physician and how we connect those dots so that we can identify step 2, which is where should the treatment take us over the next few weeks. How are we going to get there? What's our plan of care going to look like? How do we keep the physician updated? Anytime there's a change in the plan of care, we have to contact the physician. Anytime we need to change our treatment goals with the patient, we have to contact the physician. Change in medication, we have to contact the patient. Our regulations for our conditions of participation state anytime there's a change in care, we have to notify the physician. So sometimes that's a bit of a struggle, as you can understand from a physician standpoint of, man, McLaren's calling again on the phone. But I tell you, we get many more calls of saying, why didn't you update us on this? When a service failure may happen, typically it's around communication. The physician's upset because they weren't updated about a patient's change in their status. So it's very important to us from an organization that we're keeping the physician informed, we're updating them about changes, that we train our staff about updating on them, that our nurses and therapists use SBAR communication when they contact the physician office so that they don't bore you with a minute-and-a-half overview when you're just like, okay, what's the situation, what's the background, what's your assessment, what's your recommendation? So that you have the trust when that nurse or therapist calls you to ask for change in orders, that they've done a thorough assessment, they understand what's going on. Okay, so goal setting, I've kind of mentioned that. Frequency, a lot of times what we'll try to do in frequency as therapists in the home is, it may be 3 times a week for 6 weeks, or we may try to wean them down in their therapy care towards the end. If they're not going to be going to outpatient therapy, that there's no possible way they're going to get there. We're trying to, again, rehab them, but then begin to wean them off from us and have them continue with home exercise program and leave them detailed home exercise program to continue with. I've talked a lot about evidence-based, standardized testing, I should say, so far. But certainly the standardized testing drives right into evidence-based care to make sure that although we're talking about in patient's home, it doesn't change the concept still that you've got to have good objective tests. How are they doing functionally? And are using evidence-based care in your treatment, whether that's for vestibular rehab, whether it's for our stroke program that we have with our patient, and looking at intensity, duration for the care that we're providing to our stroke patients so that we can have improvement with our stroke patients. Okay. And as we progress the patient, again, if they're getting to outpatient, we want to make sure they can get in and out of their home safely, get to the doctor's office. That's a high priority. We want to make sure that they can get in and out of the house safely to the car if they're going to go to rehab 3 times a week, and are they exhausted in doing that related to the homebound status. So overall goals, I probably hit a lot of these indirectly through the presentation. I tried to not necessarily go through the slides, but try to give you some examples from a therapy standpoint of what we do, what the heck we're doing out there, when you order therapy in the home. And again, as Whitney mentioned, back in '95 when I started doing contingent therapy in the home, I'm just like, I didn't even understand it as a therapist. I'm thinking private duty, how does this all tie together? Not understanding it's a Medicare benefit for patients who need skilled intermittent care in the home for a short period of time. Again, short period, maybe 60 days, maybe spread out over a long period of time, but under the skilled direction of a physician providing that care. So there's a lot of misconception out there between private duty and home, skilled intermittent home-based care that, I think opportunities like today, and I appreciate you offering us to come in, that we can kind of go through some of that with yourselves as students, or residents, excuse me. Okay. So I'll kind of close with 2 examples, the last 2 patients that I've had. The most recent one was a 48-year-old patient who had a hemorrhage stroke. She was right side hemiplegia. going in to make my assessment with her. Same routine as I mentioned earlier. But where the assessment shifted to treatment was looking at her right hemiplegia and what is the care treatment approach we're going to use to be able to care for her arm. Whether that was NDT, facilitatory type techniques for the patient, whether that was looking at frequency and duration and the neuroplasticity approach in terms of trying to rehab the patient and begin to have her use her arm again. So we worked for about 3 or 4 weeks. A lot with the right arm. We worked a lot on ADL stuff. We tried to incorporate functional things. You know, I'll typically do treatment with exercise and immediately follow that up with some type of functional activity. So my whole goal and concept from a stroke patient standpoint is if I'm doing the exercise and getting the repetition, the intensity and duration for the neuroplasticity for the stroke recovery patient, can I transfer that into a functional task for the patient to where motor learning can occur? So for that stroke patient, that was very important for her that we tried to do a lot of those type of exercises. After about 4 weeks, we transferred her to outpatient. Again, I called the physician, said we're ready to transfer Mrs. Jones to outpatient therapy. She'd like to go to the Neuro Rehab Institute in Flint. Is that okay with you? Can you fax the order over? Doctor called back, says no problem, faxing the order over here. I called the outpatient center, said Mrs. Jones is coming. An order from the physician's coming on this date. Here's her diagnosis. I'll send over my discharge summary so that there's a safe transfer from home-based care to outpatient. Patient before that is a 55-year-old heart failure patient. Again, same assessments that I mentioned. I'll walk in, do those assessments with the patient, establish the treatment plan. For him, he was 48-year-old, 560-pound, morbidly obese, as you can guess, patient who was about 6'3". Heart failure patient. I walk in, again, do my assessments. What do I notice? Again, being in the home, I notice the bag of chips sitting by the chair. Okay? So it's not just the standardized testing, the fancy therapy stuff. It's like, whoa, man, wait a minute here. What are you doing? You know how much sodium is in here? You know your diet is a low sodium? I'll connect with the nurse on this. We'll try to tag team up and educate the patient about their condition. We'll use the heart failure training tools that Whitney mentioned about the red, yellow, and green zones for their care. So we have a great opportunity in the home to see all of those dynamics, what their diet's like, are they taking their medications. There's the medications that they show all of us in the hospital. Okay? Then when you get in the home, there's this brown bag that they say, here's the other meds I take when I need them. So you talk about med reconciliation nightmare in the home care, and it's one of the most time-taxing, consuming, frustrating things for a home care nurse or therapist is the med reconciliation in the home. So again, without being in the home, you don't always see those different dynamics. So I tried to give, I'm going to jump over this stuff, I think, for time's sake. I tried to give you, again, a couple examples from a therapy end. I don't know if there's any questions. During those assessments, I'll identify, for example, in the bathroom. Let's say they need equipment in the bathroom, whether it's a 3-in-1 commode over the toilet or they'll need a hospital bed when I see they can't get in and out of their bed. What I'll do based on that assessment is when I call the doctor about confirming the plan of care, I'll call the DME that the patient may want ahead of time or our DME that we're trying to work together with on, and I'll say, do you have this stuff in? When can you get it out to the patient? Confirm the fax number. Then I'll call the doctor and say, Mrs. Jones needs a hospital bed, a 3-in-1 commode, and this. Can you send that fax script over to this DME at this number? And that way, it's quick for the patient to be able to get the DME in their home. The coverage for it is just depending on insurance, but things such as a shower, chair, a bench, those are not covered items, but hospital bed, 3-in-1 commode, bedside commode, just depends on the piece of equipment. CPAP, BiPAP, those things. Again, are covered items depending on the insurance.
A hospital bed is covered, but a plastic chair that sits in the tub is not.
Correct. Yeah. Yeah. So we'll try to be, again, on the home care side, we'll try to be creative and call VFWs locally if the patient's got no money. I mean, I worked in the center of Flint when I was full-time. That was my territory. I had a lot of patients that struggled in terms of obtaining DME equipment. I'm calling around the VFWs. I'm calling around to senior centers. I'm trying. Yeah. Sometimes people will just drop them off there, and if you know your territory, you'll kind of know some of the ways to get things for your patients.